Hello, everybody. Welcome to the PrecisCa Hematologic Malignancies Tumor Board. Very happy to have you here. Very excited to go through some of these really interesting cases. The cases that we are going to focus on today are all patients with various forms of lymphomas. We have an outstanding panel with us here today to go over these cases. I'm very excited to be amongst them. I'm going to first introduce myself. I'm Dan Pollier from the University of Colorado, and I'd like each of my colleagues to introduce themselves. Dr. Fromm, please.
Hi, my name is Tyler Fromm. I'm an assistant professor of radiology with appointments in abdominal imaging and nuclear medicine at the Washington University School of Medicine in St. Louis, Missouri. I specialize in oncologic imaging with a focus on MRI and PET examinations.
Larry Keston. I am a radiation oncologist in Michigan, in the Detroit area. I work for Michigan Healthcare Professionals and Genesis Care USA. I'm the medical director of the Michigan region.
Hi, I'm Jeremy Abramson. I am a medical oncologist specializing in lymphoma. I direct the lymphoma program at the Massachusetts General Hospital in Boston, and am associate professor of medicine at Harvard Medical School.
John Pagel. I am the chief of hematologic malignancies and the director of the stem cell and cellular therapy program at the Swedish Cancer Institute in Seattle, Washington.
This is a 57-year-old Caucasian male with stage 4 nodular lymphocyte predominant Hodgkin lymphoma, who got 6 cycles of chemo-immunotherapy in 2014 and achieved a complete response, and is now presenting with progressive back pain. So we're going to go through the nuances of this case a bit, but we're really trying to focus on what the recommended treatment strategy here is. So as we heard, the patient presenting with middle lower back pain, performance status 0, no real significant medical, social, or hematologic malignancy family history. So this is a patient that Dr. Pagel kind of told us about back in the first case, stage 4 nodular lymphocyte predominant Hodgkin lymphoma with widespread disease. And this patient got 6 cycles of rituximab, cyclophosphamide, doxorubicin, vincristine, and prednisone, and then an end of treatment with a complete metabolic response. So, Dr. Pagel, can you just quickly take us through? 2014 was quite a while ago. This is an interesting and outlier disease. As you told us before, it doesn't really behave as a Hodgkin lymphoma. Can you tell us what your preferred strategy up front for this is, and sort of what the expectations are?
Yeah, this is another one of those cases where it depends on the patient, it depends on the clinical situation and what the goals of treatment are. I did allude early on in our first case that nodular lymphocyte predominant Hodgkin lymphoma is not the same as classical Hodgkin lymphoma, as we've been discussing in the last couple of cases. Again, I think of this kind of this entity as more like an indolent non-Hodgkin lymphoma, akin to diseases like follicular lymphoma, perhaps lymphoplasmacytic lymphoma, or small lymphocytic lymphoma. It depends on the patient and how they present. This patient presented with widespread disease, osseous involvement, splenic involvement. That's not how most indolent non-Hodgkin lymphomas present, but it can happen, and it happened here. Often, if they've got minimal amount of disease, maybe they don't have significant symptoms, or you're not as concerned about them, but they do need some treatment. Maybe even if they're a bit older or more infirmed, have comorbidities, you could treat them in a very conservative manner, like you might follicular lymphoma, with more gentle therapies. Those gentle therapies could be gentler therapies, I should say, could be a regimen of bendamustine and rituximab, or single agent rituximab as an example. And really, of course, those are all reasonable approaches, as is our CHOP, which was done here. because we're palliating these patients. It's not a surprise that this patient has relapsed. Now, I'm a little concerned about the relapse here. I guess we're going to talk about that, of course. And I have to say, I would probably have used R-CHOP here as well, just as my gut listening to the story, because of the widespread disease, the osseous involvement. I would be highly concerned that this patient could have had some underlying transformed disease from the start that was a bit occult under the surface, so to speak. Now, it has had I think around a 6-year remission, so maybe that's not the case, but I am concerned about transformed disease now. I do want to point out one other thing that I should have said earlier is that these nodular lymphocyte predominant Hodgkin lymphoma cells are CD20 positive, whereas classical Hodgkin lymphoma is CD20 negative. So here we do use rituximab targeting CD20. There's a role for that here where we don't obviously use that in classical Hodgkin lymphoma. So here you could approach it with R-CHOP. You could approach it with any of these indolent regimens. And in fact, many times in the guidelines will suggest that a regimen of ABVD would be reasonable here as well. I personally am not a big fan of ABVD in patients with nodular LP Hodgkin lymphoma because of the use of the bleomycin. I don't want to use that if I don't have to, and I don't think I'm going to cure these patients. So I would have likely been more inclined to use R-CHOP in this patient.
Great, thank you. And then Dr. Fromm, let's take a look at the scan here. Do you mind taking us through this? This is, I believe, the relapse scan.
Sure. Yeah. So in the center, we have our maximum intensity projection image that's giving us an overview of the disease, and we see multiple markedly avid discrete lesions that appear to correspond with osseous structures, as confirmed on the transaxial images shown on either side. We're on the left side, we see one side of involvement in the proximal shaft of the right humerus. There's a little bit of misregistration between the CT and the PET images there, as often occurs. And on the on the right side, we see involvement of a vertebral body with some extra osseous signal on that the PET portion of the image that kind of extends into the paravertebral space as well as into the epidural space of the spinal canal. And then we see on the MIP image multiple other sites of disease in the thoracic and lumbar spines, as well as a right acetabular lesion.
Great, thank you. Yeah, you really get a sense of the osseous involvement in that MIP image. So this patient has a needle core biopsy of one of those vertebral bodies, and we find recurrent lymphocyte predominant Hodgkin lymphoma that has focally transformed to a large B-cell lymphoma. And then we have some of the immunophenotypic information, but Dr. Abramson, is this, I suppose this is a reason to always repeat a biopsy, going back to what we talked about before. How common do you see this type of disease transformation?
It's actually quite common. Nodular lymphocyte predominant Hodgkin lymphoma is a very interesting disease. As Dr. Pagel pointed out, this was a fairly aggressive initial presentation for a disease which usually presents at a peripheral nodal location, without systemic involvement. And it's worth noting that nodular lymphocyte predominant Hodgkin lymphoma exists on a histologic spectrum with a more aggressive disease called T-cell histiocyte-rich large B-cell lymphoma. And if you biopsy multiple locations in a patient with a high-risk presentation, I wonder if we would have found more aggressive disease histologically, which would often have this T-cell histiocyte-rich large B-cell lymphoma appearance. And that would certainly have swayed me to use R-CHOP. And that's why even without that, I would have used R-CHOP up front in this patient with a higher risk presentation than we typically see for a standard nodular lymphocyte predominant Hodgkin lymphoma. But over time, we know that these patients can relapse in an ongoing way, and they can relapse with either the same nodular LP Hodgkin's, or they can relapse with diffuse large B-cell lymphoma. And a significant proportion over time, and it may even be high as a third of these patients who follow them long enough, will actually develop diffuse large B-cell lymphoma histologically. And so it is critically important to biopsy these patients at the time of relapse, because you're not just looking for nodular LP Hodgkin's, you're looking for diffuse large B-cell lymphoma, which would clearly impact your treatment plan. So this is a patient I would be approaching now as relapsed diffuse large B-cell lymphoma rather than nodular LP Hodgkin lymphoma, where I might use less aggressive therapy.
So staying with that, Dr. Abramson, then what would you say is the recommended treatment strategy here for a relapsed DLBCL type situation?
So for a patient with what appears to me like a relapsed diffuse large B-cell lymphoma, our standard paradigm has not changed dramatically over the years, though it is in evolution, as many areas are. I would still ask the question of is this patient sufficiently young and fit to undergo high-dose chemotherapy, which this patient sounds like they certainly are. If that's the case, then I would give a second-line regimen for diffuse large B-cell lymphoma, which is usually in a patient who previously received RCHOP, like this patient had. The three most commonly used regimens are RICE, RGDP, or RDHAP. So I would typically use something like RICE or RDHAP in this patient. And if they demonstrated chemotherapy-sensitive disease, would then take them to an autologous stem cell transplant. The fact that this patient relapsed fairly late after their initial treatment, about 6 years after their initial treatment, would make me optimistic that they would be chemotherapy sensitive at this relapse. We know that the patients who progress earlier, particularly less than a year after RCHOP, have a much higher rate of being refractory to their next line of chemotherapy. I'd also note that if this patient did not have chemotherapy sensitive disease, and therefore weren't a candidate to proceed to high-dose chemotherapy with a curative intent, that I would now consider them a third-line patient and who would have CAR T cells available, something we may talk about a little bit more. But for now, this patient, I would be hopeful that they would have chemotherapy-sensitive disease, second-line therapy with RICE, RGDP, or RDHAP, followed by high-dose chemotherapy for chemotherapy-sensitive disease, or CAR T cells if they prove chemotherapy refractory to the second-line regimen.
Great, thank you. So I think, the take-home points here are lymphocyte predominant Hodgkin lymphoma is a very different actor than the other subtypes. It is a more indolent, potentially indolent disease that can be treated with other, sometimes less aggressive therapies, but you're really playing the long game because it's not typically thought to be a curable subtype. It can convert to a high-grade lymphoma, and for that reason, biopsies are crucial when patients progress. And a patient such as this would be treated with the first-line preference would be a high-intensity chemotherapy regimen with an intention to consolidate with an autologous stem cell transplant.